Good morning, or is it good evening, Dr. Solara? It's morning there. Bonjour. I'm practicing my bad French on you. Uh, Welcome again to the Balance Con. Uh, we understand you have a presentation on juvenile meniers. So we're looking forward to your presentation. Hopefully you would be able to stick to time, about 15 minutes. Is that okay with you?
Yes, yes, for sure.
Okay, Dr. Solara, you have the
So,
floor.
thank you. So, good morning, everyone. And hopefully, today I'm going to talk about Meniere and children. I just want to ask if any one of you has seen a Meniere case in children. I know that throughout my career, I was only kind of lucky to see only two cases.
Yeah, I think it's very rare, so you won't get many answers
Yes,
from
it
here.
is
Yeah.
very rare. And I'm going to talk briefly about my two cases. Um, the first case was actually Meniere. She was a 15-year-old girl, and the second case was one of post complication of cochlear implant. So we do believe it could be classified as a pseudomeniere. Um, I'm sorry, but I can hear feedback. Is it possible to
Sorry? No, we are
yeah,
not
the
interrupting.
feedback. Yeah, but the feedback is very high.
Feedback is high. Uh,
Yes, I mean the echoes are high.
okay, so we'll just work on that. But we can hear you loud and clear. You could just keep talking.
Perfect. Perfect. Okay. Let's make sure this is working. Okay. I'm just gonna make sure that you can see my screen. Okay. So I assume previously, in the previous lecture, they explained what is Meniere and the possible causes related to Meniere regarding the endolymphatic fluid pressure, the increase in fluid pressure within the endolymphatic fluid. So I'm not gonna go into this. So now all I'm gonna say is that the causes are almost the same in adults and children. So a little bit of history. I would like to say that after being um, described by Prosper Meniere in 1861, in 1938, the first case report was done by Frau. 1940, Simonton talks about a case which is a young lady in his clinic, and her case history goes back to starting these episodes of vertigo since she was 4 years old. In 1941, the real juvenile Menieres were reported by Omberdani and Aubrey, who talked about a 12-year-old boy whose dizziness were not tolerable anymore and they had to do a partial transaction of the acoustic nerve. This followed in 1944, where Ford talked about, and this is our real first cohort, if you want to say. He talked about a girl who was 4 years old. She had absence of vestibular response in one ear, which is the right side, with fluctuating hearing on the left side, and she had episodes of vertigo and vomiting. He kept on following her. At the age of 6 years old, the frequent vertigo attacks increased, they became stronger. And by the age of 15, she couldn't tolerate it anymore. And they went and they did a partial transaction of the acoustical nerve. So, 1944 with Ford is our first cohort. This is a child that we were able to follow. Uh, if you want to know more about the history of Meniere in previous cases, I think one of the very nice articles written about it, about the history, would be this article by Meyerhoff in 1978. But before Meyerhoff, Parving in 1976 mentioned two cases of Meniere's out of their 850 children examined in one single year. And we're starting to talk about prevalence now. Bido mentioned in 1977 a 3-year-old female and a 10-year-old male. All of these are case reports with a bit of comparison between adult and children. And Mayor Hoff, which I just mentioned, is the one who brought us 8 cases. That was a big number, 8 cases. And as you can see here, the age where these attacks start is fluctuating even. Like some kids start as early as 4 and 5, some we can see around puberty. And the frequency, it could be as 1 per month, twice a week. And all of these kids have underwent surgery and they kept on following up on them. So, take home message, yes, we have case report, but one of the things that we've mentioned, we've seen in these case report that each individual may experience symptoms differently, and I'm 100% sure it's the same in adults. The symptom can occur suddenly and may happen daily or infrequently, and this is what makes Meniere in kids even harder, because this is something you cannot predict and you cannot explain properly to kids. So let's see what are the complaints we see in children. Ringing. And when a child comes to me not able to explain what's happening, we will have to help them explain about tinnitus. And ringing, we can use bell, we can use the whistle, sorry. Vertigo and imbalance is going to be clear, and it's going to be a clear complaint. Hearing is not stable. You will not be able to, you will get complaints from the parents saying that they don't want to listen, and the child is going to complain and say, no, I'm not able to. And this on and off thing, or these episodes, are sometimes underestimated by parents or discarded by parents. Headaches, and this is a point that we're going to come at the end in the last comment, I guess. Headaches in children are associated with Meniere, vomiting, nausea, and sweating during episode. Now, oral fullness is an issue, because I will not be able personally to ask a child about oral fullness unless they're 8 or 10. And younger children, it's harder to explain this concept. So it's not that it's absent, it's just harder to get the answer from the kids. Now, what are the possible causes? And possible causes are many, like allergies, viruses, otitis media. Family history of Meniere has been associated with juvenile Meniere's. Head injury traumas, these are a couple of case reports that shown post head injuries. Pseudo-migraine is seen. Pseudo-Meniere were seen, and finally migraine. And again, I come back to migraine at the end. The correlation, the connection, and I'm sure I'm not sure, but I guess someone has mentioned the connection between Meniere and migraine. Okay, so I really like this picture, and it shows that different causes may lead to endolymphatic hydrops, and these are the major symptoms that happen. And usually I have this in a French version of it, and I use it as an example to explain to adults and rarely children what is happening. Just give them that there is not that for us to be able to treat, we need to see the reason as much as we can, although we cannot remove and delete Meniere like other cases, but we can try to control. Now, what are the prevalence in children? Now, a case report by Akaji in 2001 give us an idea about the percentages. In 1978, Stanley showed a 0.4%. Mayerhoff, which I just mentioned, showed a 3%. And this, we're talking about children with Meniere disease compared to total number of patients with Meniere disease. So out of the adult population as well. If we take children with Meniere disease compared to the total number of children with vertigo, we go down to 1.5% more or less in Hostler's study, and it can go up to 4% in a newer study by Bauer and al. In my opinion, migraine and migraine is more frequent, definitely, than Meniere in children. Recent studies, and this is in 2005, not very recent, but Gottfried Aust from Czech Republic showed that out of the entire group, he had 2.75% of the Meniere patients were actually children aged as young as 5 years old or within the 5 to 17 years old bracket. And they were mainly diagnosed based on case history, and other results were completely normal. Case history gave them the idea that most probably these are Meniere's disease, and they went with imaging. The new item that they mentioned here in this article that I would like to talk about was they treated with vitamin B, and they said, and they underlined the importance of not only rehabilitation, providing vestibular rehabilitation with these children, but the fact to communicate how these children are limited in their future plans and occupation. And that's a very important talk to do with parents once we confirm it's Meniere's disease. They are limited what they can do and how they can progress at school. So this we'll discuss in a few seconds. Another rare and another article that is published in 2006 talks about that's published by Chong and Al, gives you a prevalence that fluctuate between 0.4 up to 7% out of the adults. And in their sample, it was 2.6% of the children with vertigo. Now, diagnosis and treatment. Juvenile Meniere disease, which is a Filippo and Al article published in 1985, they mention or they explain that yes, you need to do audiovestibular tests. However, do not expect anything on the results. And what could be the steps that we use? It would be hearing tests, and we're going to be expecting low frequency hearing loss, which is fluctuating. Will I see it always on children? Not necessarily. And this is why I really like to perform an OAE on children. I'm not sure if anyone mentioned previously, I'm sorry I wasn't able to attend the previous lecture, if anyone is performing OAE on their Meniere patient, but I really see a difference in adult, and I would recommend doing it on children as well. Balance test I'm going to discuss in the next slide, but I would do the basic screening on these children, and I will do them every time. So I need to think smartly what could be a beneficial protocol. MRI scans for sure, ECOG, okay, and blood test as blood test to try to confirm it's a Meniere disease. Now, pseudo-Meniere was first introduced by Crow in 1938, where he mentioned that these kids, there are some kids where will have similar symptoms as Meniere, but around the age of puberty, this will disappear. And you're going to see an increase in, they will start around the age of 4 and 5, where it's not very severe, increased severity between 6 up to 10 years old. So once you reach puberty, it will disappear on its own. So these are called pseudo-Meniere cases. Now, let's go back to the assessment. You can do Romberg and posturography, which is simple, and you can see a different, you can see a difference. But remember, the posturography is a functional test. It's just going to tell you how they are capable of, this will be a baseline for you to compare with vestibular rehabilitation. Calorics, we will do calorics in case needed, but and SVINT. However, let me be very honest, do not expect always a positive answer. VHIT, in my opinion, in Meniere disease is not very effective. I don't know how much people, I don't know what was the feedback in the previous lecture, but in my personal opinion, VHIT is not very useful in assessing Meniere in kids nor in adults. And I would do VEMPs. Definitely, I will do VEMPs on all our children. It will give us an idea, especially if we go with with 1,000. So a recent study in 2018, just recently, was published with Yang and Al, and what they did was they collected 24 Meniere diseases that are kids that are less than 15 years old. The prevalence was 2.3%. And what they found, which was interesting, is the ratio female to male was compatible with the adult, which means that the females were more prone to have MD than males. And the results are interesting. So here are the results when they did on all children, hearing test, CVAMP, OVAMP, and caloric test. I'm going to just take a minute to go through the slide. Hopefully you can see them clearly. So when they did the audiometry test, only 25% had an abnormal audiogram versus adults, where it was 65% they had abnormal results. The CVAP test was abnormal in only 20% of the children, of the ears, sorry, that were tested, and versus adults where it was 45. OVAMP was not very helpful, it was 13%, and caloric test was only 12%. As you can see, the majority of the results when testing will come up with a normal result. So the question comes in, is it necessary to go through, will it be really necessary to go through all of these testing in children? Now, audiometry is for me necessary, because if you see a severe hearing loss, we will have to treat with hearing aids as necessary. But is it really, really necessary to perform these tests on these children if we're saying that the results are coming negative? In my personal opinion, I'll go with the screening, and keep that in their folder as screening test, which means I don't have to actually send the patient to the vestibular lab. These are the screening that I do in my own clinic, keep records. And in case I see an nystagmus, that's when I think, okay, let's do beyond the screening test and record this through oculomotor, through a full VNG testing, including oculomotor calorics, skull vibration induced nystagmus. I will do the CVAMP and OVAMP. I will, with all my respect to everyone, if my hit is negative, I will not send the child for regular VHIT. Now, the treatment in children is very similar to adult, and we're gonna do change in diet, eliminating caffeine, and by caffeine, it's not only coffee, it's even Coke, etc. Chocolate. Okay, alcohol, I'm gonna mention it here because some countries, like France, for example, children will have a sip of wine on Sundays, so that's a no-no. Salt and salt, and I would really recommend, similar to our migrainous patient, to create a diet agenda. And what I mean by a diet agenda, they will have, similar to their school agenda, an agenda where we're gonna have a smiley face or a sad face, depending on how we feel today, and they're gonna write what we had for lunch, or what they had food that is different than what is on our regular diet, to be able to see if that trigger happens later on. We tried asking the patients, especially children, to write everything they were eating, and to be very honest, it was very hard. So what we did was we asked them to take pictures of their food, especially, kids with their cell phones around the age of 11 and 12. They like this, they keep it as with picture, it was easier. Vestibular therapy and behavior therapy for me are very important, and we can do this through an actual treatment therapy with a physical therapist, or they can join a yoga class or sports, which I'm going to talk about in a minute. Medication, I'm not an ENT, which means I'm limited of what I can recommend, but I will leave it to the ENT to decide what medication will fit best with the patient with Meniere disease. I know that we will have to reduce dizziness, elevate symptoms, and reduce fluid if possible. Now, surgery is the last option, and surgery, in case we have, in one of our cases, the young lady's case, we spent an easily 6 months explaining all the possibilities of what's going to happen post-surgery and how much this will affect her life. And she opted for it. She wanted these vertigo to stop. And it's really hard for a child to grow up normally if they have so much episodes of vertigo happening. Again, reduced fluids. We started with diuretics, and we had to monitor her. We had to monitor her in the last period of time, almost every 2 months. We gave her the avoid list, and I'm assuming a lot of you guys have similar avoid lists where it's decrease sudden movement, do not allow the child to walk alone during attacks, TV reading during attacks should be decreased, and we give the similar, almost the same list to the migrant patient. Um, when it comes to kids, do not ride bikes or climb trees until 1 week after the attack, at least. And do not take the metro or the bus.
Dr. Solara,
It
we
would
have
be a
about
recommendation from our end.
Dr. Solara, sorry to interrupt, but
Yes.
about 3 to 4 minutes. Could you stop after 3 to 4 minutes so that we can go
Sorry,
on?
I didn't hear you.
Just keep to time 3 to 4 minutes if possible.
Yes, sure.
Yeah.
I would just like to talk about something at the end, and I will open it for a question. And this would be, the last point is what to explain to parents when they discover that it's Meniere. Just make sure that they do not check Dr. Google very often, because it's scary what you read online. Make sure that the schools are informed, because the school nurse needs to be aware of the situation. We follow up every 6 months if it's stable, even if there is no attacks, and make sure that whatever they do it with a partner, and it could be sports, etc. And the partner is well aware of their situation. I will just want to ask, and this is the question I have, I keep on asking and hearing, migraine and Meniere and BPPV, are we talking motion sickness as well? Does the diagnosis make a difference? And I would stop here and hope someone can help me. And I go back to the point I asked yesterday. If I have migraine patient, I have Meniere patient, do really the name makes a difference in children, at least? Thank you.
Thank you very much, Dr. Solara. So the floor is open for questions. I would start by asking you one question. You did not specify what surgery you did on that child.
We went with the neurectomy because Genta injection were not helpful.
Okay. Any other questions? Because I think she has opened up a chapter of pediatric vertigo and pediatric Meniere's, which quite honestly I had not considered to date. I have never maybe treated such cases. Maybe my practice is not entirely vertigo. So for those of you all who do a lot of vertigo practice, can I have a show of hands? How many of you all treat pediatric Meniere's? Pediatric
Can you
vertigo.
please repeat the question?
No, hang on. So could you please ask her the questions which you have in mind regarding pediatric Meniere's? Anybody wants to ask?
I'm sorry, but the sound is very far. I'm not able to properly
No,
hear.
we're just getting to the question. 1 minute. Yeah.
Okay.
Are you doing routinely the glycerol test or other specific test for audiological evaluation to come to the diagnosis of Meniere's in pediatric patients?
Okay, again, I'm really sorry, but the sounds are, there is a huge echo from
Okay,
your end. I'm not able to
that's the
hear
traffic
properly.
in India, but that's okay. Do you do dehydration tests for hearing?
Yes, I do. Yes.
Can you hear me? Yeah.
This is it. We're doing, we do dehydration tests on children, similar to, we also do blood tests on, with glycerol, if that's, we do a full profiling, yes.
Okay.
We do dehydration testing, yes.
And you use glycerol or you use thiazides? What do you use?
Glycerol.
Glycerol. Okay, fine. Any other questions? And what is your follow-up on these patients?
Sorry?
What is your follow-up on these patients? How long have you followed up pediatric patients?
Now, as I said, I only had 2 cases till now. The 15-year-old is already 22, but I keep on following up with her.
And do they improve or do they worsen when they touch puberty?
Sorry?
Do they improve or worsen when they touch puberty?
No, her case shouldn't improve because I do agree that once you have real Menieres, it's a lifetime.
Anybody else would like to comment
And
with that? Yeah.
natural.
So thank you, Dr. Solara. I think you've opened up a lot of minds here, and we hope that we will remain in contact with you, and we hope that this scientific association will continue. Thank you very much.